Hello everyone, it's Dr. Locklear and I'm coming to you with Exemplar 48.A Clinical Decision Support Systems. This is in Volume 2 of your Pearson book and it begins on page 2820. So let's look and see what we're going to talk about today. So we're going to describe the role of uniform languages in clinical decision support systems, describe the use of computers in nursing research, and describe the use of computers in nursing administration. And again, as we said in the informatics lecture, that computers are very useful. They are used every day for an array of resources and services. So what is our overview? Clinical Decision Support Systems, what are these? The CDSS. So these are an important addition to the electronic health record. They can be a general system and they're used as developed by the vendor, or it can be customized for the organization. So whatever the organization would like to have in these programs, that can be created as well. A clinical decision support system uses a knowledge base and program rules. They use protocols, evidence-based guidelines to match against patient data in the electronic health record and deliver alerts or recommendations to the provider. So again, I said that in the informatics, if you put in vital signs that are abnormal, it'll flag it red, or it'll let the nurse know when something needs to be documented or a medication needs to be given. It'll alert the nurse that if a patient's becoming septic according to the information that they put in the system. The support system can improve patient care through the reduction of medication errors. So when you scan a medicine and it's the wrong medicine, it'll alert you and say wrong medicine or wrong time or wrong dosage. And you need to pay attention to those. Do not override it and disregard it. You look at it and see what the problem is. The clinical decision support system can be challenging if it's not set up correctly. Too difficult to navigate, too many alerts, which leads to fatigue alert. So what that means is you hear that call bell go off so much you just don't hear it anymore. You see these alerts flash up so often on your computer screen you don't pay them any attention. Users become dependent on the system and not use their own critical thinking and judgment. So again, these systems are alert systems. They're created by the vendors and they're purchased by the organizations. They match against patient data in the electronic health record, and they provide alerts and recommendations to the provider. Again, if a patient's running a fever, it's going to alert you that that is abnormal. It'll alert you to signs of infection, of medication errors, when something needs to be documented, a new doctor's order needs to be carried out. Again, it can help reduce medication errors because it has checks and balances with it, and it makes you check. Please, 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 when you are administering medicines, please take your time, pull medicines in the order they are on the screen from top to bottom on the MAR, and make sure you're doing your 6 and 7 rights of MedPass. You scan your patient first, you do your 2 identifiers, and then you pull and scan one medicine at the time. These are things that we will work on this summer. Again, there are challenges, as we mentioned just a moment ago. So what is the nurse's use of clinical decision support systems? So they found 4 factors that nurses use these. They tend to use the guidelines more often early in their careers or when caring for unfamiliar patients. They use the guidelines to back up their decisions. They use the technology that supports the number of reminders and to help them say, yes, this is something I need to look at right now. So some of the factors are patient factors. It gives them alerts. Nurse factors, it helps us do checks and balances. Nurses tend to use guidelines more early. Like I said, as we become more seasoned nurses, we should be depending more on our clinical judgment and our critical thinking skills. We use these systems to back up our decision. Technology that supports this is limiting the number of reminders, strategic locations of workstations. It's really not a good idea to document in the patient's room if you don't have to. We don't want to invade on their privacy. Does the nurse know how to use the technology, and are we using good ergonomics? And if you'll see the little design here, this is the clinical decision-making model. And so you have self-confidence, feeling competent, you feel supportive, and you have nursing education to help you make these decisions. So, what is the nurse's use of clinical decision support systems as related to barriers? So, look at the nurse in this picture. She's overwhelmed. Nurse, 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 nurse. Every time she turns around, somebody's calling the nurse. And it can be overwhelming when you're trying to provide patient care and keep up with all the requirements that the system requires you to do. You're either providing care or you're working on the computer, one or the other. Some of the barriers: a heavy workload, a poor interface, lack of trust in the information. Unfortunately, some people do document items that are inaccurate or fraudulent. They may put that the patient voided when they have a Foley catheter. They may put that the patient's turned and repositioned every 2 hours when that doesn't happen. And then another barrier is lack of reminder flexibility. Again, we get that computer fatigue, alert fatigue. We just kind of overlook it because we see it so much. So computers are used in research to help understand the barriers to using best practice promoted by the clinical decision support system. One study found that some nurses prefer to rely on their own gut instinct, and sometimes that is a good thing. If you are assessing a patient and something doesn't feel right, you need to act on your gut feeling or your intuition about that situation, and that does come with practice. Computers, again, in nursing research, when the electronic health record, computers available to all nurses in all practice. Sometimes we don't have enough computers for the nurses to use, and they have to share, and then there's lag times in getting on the computer and getting stuff documented in a timely manner. Should make it easier to conduct research. So we use the computers to go in and find, information about medications, discharge teaching, information related to disease processes or a new procedure that the physicians order for the patient. The nurse can use the electronic health record to research the patient's medical history, why was this drug ordered? What is this drug? What do I need to know about this drug? And they can use the internet for a literature search to see what the research says about best practice related to patient care. Computers in nursing administration. These are tools to manage their budgets and create schedules and look at those quality indicators we were talking about in the informatics lecture. Productivity, what does that mean? It means that I have enough staff available today for the number of patients or census that was on the unit, or was I short-staffed? If I was short-staffed, then I didn't meet my productivity. Or do I have enough patients to offset the number of staff I have? So if you're ever a unit manager, you'll learn how to do the productivity tool, and it is on the computer. I've actually done that. Use of dashboards puts the information of the electronic health record at the administrator's fingertips. Information such as quality indicators, results of surveys that were done, charts and graphs, and just key information about what they talk about here, the performance indicators. How did your unit perform on preventing falls and preventing pressure ulcers and preventing UTIs? Some of the information is displayed in real time, and some of it is from surveys that are done. The electronic health record can create those reports that help us track data over time, so I can compare, how many pressure ulcers I had this month compared to last month. In human resources, how do they use it? They track personnel, so every time someone's hired, an electronic record is created for them. They monitor your license. Are your license current with the Board of Nursing? They track your hospital education that's mandatory. All hospitals require nurses to have a certain amount of education every year. They track your attendance. Are you beyond the attendance that's or the days missed that's allowed? They track your yearly performance reviews by your unit manager. They do the payroll. They track, sick time and vacation time and overtime, because overtime costs money, so they need to track that. Medical records. Of course, this is the medical record for the patient, and it's got all their demographic information, their insurance information, why are they hospitalized, where is their room, where are they assigned, and it also tracks those what we call ICD-10 codes, and see right here that ACPS, these are some of your HCAPs, but coding is for the ICD-10. Like every diagnosis you have has a code, and that's what goes to the insurance company, and that's how you're billed according to the code. Facilities management, they use it for supply and demand. How many supplies are going to each unit, how many supplies this unit is using, how much is wasted, how much is signed out for, and they use it to help order supplies and keep up with tracking those materials, which is very costly for the organization. The budget and finance, these are two separate billing systems, professional billing and hospital billing. So when you go in the hospital, you'll get a bill for your hospital stay, room and board. Professional billing will be for the doctors that took care of you, the radiologists, anybody like anesthesiologists that put you to sleep, any lab tests that you've done, but the hospital bill is just strictly for room and board. These systems share information with the insurance companies, with materials management, and with people who oversee staffing. Quality assurance and utilization reviews. This is where they go in and they review why is the patient there, and does the patient need to be in the hospital? Is their diagnoses and their condition justifiable to justify a day in the hospital? I used to be a UR and case manager, and I can tell you I had to review charts every day and tell the physician, this patient doesn't meet criteria to be in the hospital, you need to discharge them. And they didn't like that very much. They thought I was trying to tell them how to do their job. But the longer you stay in the hospital, if the insurance company doesn't pay for it, then the hospital's losing money for that. Accreditation, we talked a little bit already about the Joint Commission and the Centers for Disease Control, Centers for Medicaid and Medicare. Again, they track when these agencies come in and survey you, what time of the year they're supposed to come in, so you can be prepared. And all the data, all the surveys and everything that they do in the system is there for the CMS and the Joint Commission to review when they come in. So again, these systems are a way to gather data, and so when each of these agencies come in to review you for accreditation, this information is available to them right there on the electronic record. And that's it for this exemplar.